Hello and welcome to today's webinar, Left Atrial Appendage Closure, State of the Art, sponsored by Elsevier's Clinics Review articles and Interventional Cardiology Clinics. Please note your line will be muted and the presentation will be recorded. You may submit questions at any time using the Q&A feature located on the right. Today's presenter is Apostolos Tzikas. Thank you for being with us today, Dr. Tzikas. Apostolos Tzikas, MD, PhD, FEC, is an international cardiologist specialized in structural and congenital heart disease. He works at AHEPA University in Thessaloniki and Interbalkan Medical Center, Thessaloniki, Greece. He was trained at the Montreal Heart Institute and has a PhD from the Thorax Center, Rotterdam, supervised by Patrick W. Sarais, entitled The Role of Advanced Imaging in TAVI. Dr. Tzikas is considered a world expert in left atrial appendage occlusion. He is responsible for the AMPLATZER cardiac plug registry, which has collected data on greater than 1,000 patients treated with LAAO in 22 centers worldwide. He is an experienced clinical proctor for St. Jude Medical and Abbott in LAAO and TAVR, with hundreds of cases performed in greater than 30 countries. Dr. Tzikas has published several clinical research papers in the field of LAAO and atrial fibrillation, and he was the leading author of the Munich Consensus document on LAAO definitions, endpoints, and data collection requirements for clinical studies, a position paper which is endorsed by ERA, EAPCI, and other cardiology societies in Europe. Recently, he is focusing in the role of advanced imaging and in technical optimization of LAAO procedures. Dr. Tzikas, please go ahead.
Thank you very much. Thank you for the kind invitation to present on this topic. We'll talk about left atrial appendage closure, and these are my disclosures. So there are several topics to cover today. The first question is there any clinical need for this procedure? We will briefly talk about the history of left atrial appendage occlusion. We'll present some data, general data in subgroup populations. We'll talk about the general principles of LA closure. We'll describe the LA anatomy and the implications for device closure. We'll talk about the imaging and the advantages of having a cardiac CT before doing this procedure. And then we will talk about the procedure itself on a step-by-step basis, and how to avoid and respond to common complications. So there are many things to cover. So let's start quickly, asking the question whether there is a clinical need for this procedure. We know that atrial fibrillation is a very common cardiac arrhythmia and increases the risk of embolic stroke. Up to 3 million patients per year suffer from strokes related to atrial fibrillation, and these strokes tend to be very severe and disabling. So is there a clinical need? Do we need the clot? Do we need the thrombus? The thing is that the clot is something good. If somebody gets hurt or has a trauma, we need clot so to stop hemorrhage. But on the other hand, when the clot is formed in areas and places of the heart that we don't want, like in atrial fibrillation, as you can see in this video, the clot might move from the left atrium and particularly from the left atrial appendage and go through the left heart circulation, so the mitral valve, the left ventricle, the aortic valve, and unfortunately, in most cases, it goes to the carotids and causes a stroke. Even a small clot might cause a very severe stroke. So it is very important to prevent that. Now, the most common and the most widely accepted therapy is the blood thinners, the oral anticoagulation. But still, we need to establish a balance between the stroke reduction on the one hand that this medication provides and bleeding complications. Because right now, especially in the elderly, it's very difficult sometimes to find this fine balance. Why is that? Because in many occasions, patients that have atrial fibrillation also have a high risk for hemorrhage. As I said, elderly patients, patients with a history of major bleeding, gastrointestinal diseases, chronic renal failure, coagulation disorders, patients who had an acute coronary syndrome who have received stents and require prolonged antiplatelet therapy or antithrombotic therapy, or patients with mental disabilities or a risk of frequent falls. These patients are at high risk for bleeding. And although the current, the gold standard therapy right now for the prevention of stroke for atrial fibrillation is oral anticoagulation, and according to all guidelines, unfortunately, only less than 50% of patients are treated according to the guidelines. And this is very disappointing, as you can see here in this very large registry that was published in JAMA Cardiology in 2016. So the question is, why is this happening? Unfortunately, right now, we cannot do any genetic modification of the human coagulation pathway. So you lose something and you win something. You have less stroke and you have more bleeding, and vice versa. And this is a limitation of, let's say, the human body. So the second question is, where is the thrombus? And we see that in this meta-analysis that the location of thrombus in non-rheumatic atrial fibrillation in more than 90% of cases is in the left atrial appendage. So here you see an example of a cardiologist who was performing a transesophageal echocardiogram, and he saw a clot on the left atrial appendage, and the clot moved. And unfortunately, this clot created a major stroke in this 43-year-old patient. So that was unfortunate. So how did it all start, all this LAA closure therapy? It started around 20 years ago with this device that you see on the right side of the screen. This is the Plato device that it was designed by Michael Lesh, and got a patent for that. You see it looks like a ball cage. Unfortunately, this device didn't go to commercial use. Only a few cases were done. The first case was done by Horst Sievert in August 31, 2001, so quite a few years ago. And then, after this device, we had the WATCHMAN device. And the name of the WATCHMAN is related to the never delivered speech by JFK, President JFK in Dallas. And he was about to talk on the WATCHMAN on the walls. And this is how people got inspired and gave this name to this device. And these are David Holmes, Vivek Reddy, Sai Bakar, among people who are pioneers in LA closure and worked a lot on the WATCHMAN device and how to get this introduced to the world and to the United States in particular. On the other hand, we have the AMPLATZER devices. And the AMPLATZER devices are used in several structural heart disease interventions. And here I show you the first-in-man catheter-based LAA occlusion with a non-dedicated AMPLATZER device. And this was performed by Bernie Mayer quite a few years ago. So this is Bernie Mayer on the right and Kurt Amplatz on the left. And you see two devices that were designed, the AMPLATZER cardiac plug and the AMPLATZER Amulet, specifically designed for LAA closure. So in terms of history, the first device was Plato, and then non-dedicated AMPLATZER devices were used, and then the WATCHMAN device in August 12, 2002, and then we had another patch that didn't work so well, and then we have the AMPLATZER cardiac plug and Amulet and other devices. So again, these are devices that were used, and other devices that are in the pipeline. They are in several stages of development. In the US, there is the Lariat system. This is not purely endocardial device, so I will not discuss that as much. And we'll go to the data now. So the most important data on this procedure is the randomized trial, the PROTECT-AF study, which was done to compare a WATCHMAN device versus long-term warfarin therapy. And this was done quite a few years ago with a non-inferiority design, 800 patients. And the design of the study was, as you see in this image, One part of patients, the control group, was taking warfarin, and the other group received the device, warfarin plus aspirin at the beginning, and then at 45 days, if the device looked good, there was no peri-device leak, the patient was stopped from taking warfarin and was receiving only aspirin. And these were the first results of this study with the primary endpoint of cardiovascular death, stroke, or systemic embolization. The device was non-inferior to medical therapy. In all-cause stroke, the same. It was non-inferior to medical therapy, and it was superior actually to medical therapy in terms of hemorrhagic stroke, which made sense because the patients were off anticoagulants for quite a few years. What was really very, very promising, and I would say striking in terms of data, was the PROTECT AF 4-year results, where we see that in the intention to treat population, in the very hard clinical endpoint of all-cause mortality, the device group performed better than the control group. And just to give you an idea, these are the studies that were done with the WATCHMAN device, and some of them were registries, others were randomized studies. We see that the main benefit that this patient had was less hemorrhagic stroke plus less cardiovascular or unexplained death. That was a meta-analysis presented in 2017. And this is a comparison that is, of course, may look a little arbitrary, but still, it is a comparative that gives you an idea about the mortality reduction that this study showed with the WATCHMAN device as compared to the medical therapy with the new anticoagulants studies. Of course, these were not the same patients. You cannot do direct comparisons, but it gives you an idea on the benefit. The same time in 2017, we have the Evolution registry when that was non-randomized. Again, it compared this time patients that were not eligible to anticoagulation, which is the main target group for this therapy, and it showed a very important reduction in ischemic stroke as compared to a control group that was not the actual patients, but an estimated control group with a CHA2DS2-VASc score. The CHA2DS2-VASc score predicts the stroke that these patients would have if they were not treated with anticoagulation. At the same time, we have the HESBLED score, which is a score that predicts bleeding if somebody is receiving anticoagulation. And we see that we have an important reduction also in bleeding in this study. So all these data and all these studies resulted in March 13, 2015, to the US FDA to approve this device for the use in patients with non-valvular atrial fibrillation who are at an increased risk for stroke. And they are deemed by the physicians to be suitable for warfarin, but the key here is a long or short-term warfarin. With the device, you get a short-term warfarin, so then you go to number 3, and they have an appropriate rationale to seek a non-pharmacological alternative to warfarin. And this is how it all started in the US. My personal experience is more related to these devices, to the AMPLATZER devices, so I will share that with you soon. In particular, this device, which is not approved in the US right now, but it's approved in many other countries in Europe and worldwide. It has a slightly different mechanism of action, 2 layers of closure, as you can see here. I was privileged to lead this registry, which was published a couple of years ago. And at that time, that was the largest real-world representation of the ESC guidelines, which we will talk about very soon. Just briefly to show you the study, we had 22 centers. The first patient was enrolled in December 2008, the last in November 2013, more than 1,000 patients. And the difference here, as compared to the PROTECT AF study, we had 2 differences. One was that these patients were not eligible to oral anticoagulation. And the second is that we didn't give them any oral anticoagulation post-procedure, so they received a dual anti-platelet therapy for 1 to 3 months on average after the procedure. And I apologize for the quality of this slide, but you can see that there is a previous major bleeding was the main indication for LA closure, followed by high bleeding risk. Then we had the coronary artery disease and stenting, drug interactions, stroke on warfarin, etc. The subgroup of stroke on warfarin, this was a minority. However, these patients were treated not because they had a contraindication to oral anticoagulation, but because they had a non-effective anticoagulation. So it's a special group. We'll discuss that very soon. Now, here we see the results of this study that was published 2015. Again, we have a comparison of the actual outcomes of these patients in stroke reduction as compared to the estimated stroke per year based on the CHA2DS2-VAS score. And on the right side of the screen, you can see the reduction in bleeding. And just as a note here, in these 2.3% of strokes at follow-up and 2.08% of bleeding, we did include all the peri-procedural complications. And there were quite a few, because I would say 1/3 of those was peri-procedural, because that was a new technique at that time. So right now, I would say if we repeated this study, we would have, I believe, even better results. But nevertheless, it's quite reassuring to see a 60% reduction in both stroke and bleeding. And just to remind you, the balance we try to find between stroke and bleeding. And again, here I show you the previous slide on the potential patients that might benefit from this procedure. So since we own the data, that was a physician-initiated study, all these centers, mostly from Europe, we did some subgroup analysis to dig in to see whether we will find something in subgroup populations. For example, patients with previous intracranial bleeding. It's very difficult to manage these patients in clinical practice. And we had approximately 200 patients in this registry. What we found is that we had similar procedural success or major adverse events, a significant reduction of stroke and TIA, and a remarkably low frequency of major bleeding at follow-up. And this is how it looks. If you remember the 2.3% total strokes, in this subgroup we had 1.4%, so greater reduction in stroke. And if you see on the right side of the screen, we have a 2.1% total bleeding events. And if you see the patients with the previous intracranial bleeding on the first column, that was really remarkable. We had almost no bleedings in these patients. And the main reason to explain that is the fact that we didn't give any anticoagulation to these patients. This study was confirmed, I might say, from another single-center study from Denmark, where they did a propensity score analysis, and it is the subject of a randomized clinical trial that is now enrolling patients in Scandinavia. It's called Stroke Close trial, which randomizes patients to receive LA closure versus the new oral anticoagulants. So we believe that this study will give more data on the new medications, which was not available, by the way, during the PROTECT-AS study or the AMPLATZER cardiac plaque registry. Now, what about patients with renal disease? This is another subgroup of patients that we see in our hospitals, we see in clinical practice, but usually they are excluded from studies. So the benefit of the advantage of this registry is that we had these patients. It was an all-comers registry, so we investigated them, and we saw that they had similar procedural safety, with a dramatic reduction in both in stroke and TIA. And the only observation that we made that made sense is that the patients with end-stage kidney disease had overall lower survival and the same frequency of major adverse events at follow-up. What about the elderly? This is a common question. Is it safe? Is it okay to do an octogenarian or even older patient? We didn't find any difference in that. The only difference we did find was that we had some more pericardial effusions and cardiac tamponades in older patients. So if somebody is performing this procedure to older patients, should be more extra cautious about this. How about the stroke severity? Not all strokes are the same. We found that 81% of stroke that occurred, these few strokes that occurred in this study, the 81% were non-disabling. So the patient will ask, okay, stroke, but what do you mean? If I had a stroke that doesn't interfere with my life and my daily well-being, so okay, I'm not so worried. Whereas a disabling stroke is something very different. Now, single aspirin therapy post-LA closure, this is another sub-study and very important one from Denmark again. They showed similar results, so very promising. Instead of giving dual antiplatelet therapy after the procedure, many centers, and we will discuss that later, many centers choose to give only aspirin. The per-device leaks are really small with this device and not clinically relevant. If I may say, right now we don't accept a large leak. Personally, I don't accept any leak, but occasionally you may see a minimal or mild leak with these devices. And this is a small comparison between the two devices, not randomized, of course. WATCHMAN might have a few more leaks as compared to ACP, but again, the clinical implications of that are not important and they are similar to both devices. Now, the Amulet study was sponsored by the company at that time, Senjin Medical. It was used the Amulet device, which is a second generation AMPLATZER device. Similar design, if I might say. Many centers, dual antiplatelet therapy post. And these patients, the main indication was a history of previous bleeding, major bleeding, high Charles-Vaz score and high blood score. And a minority of patients, they had a stroke on warfarin as indication, and the majority had the contraindication to the oral anticoagulation therapy. And this study was very promising again, mainly related to the total major adverse events, which was 2.0%, and it verified that the closure rate of on TE with a core lab was excellent. And here is a comparison of the ACP registry that I let's say led, and we had a device or procedure-related complications of 5%, and we have quite an improvement with the WATCHMAN evolution registry and the Amulet registry, almost half major complication rate, which is an important part that we will discuss at the end of this webinar. And this is another randomized study that is currently ongoing in the United States. I had the privilege to help with this study. I proctored most of the centers that were involved. And this is a one-to-one comparison between Amulet and WATCHMAN. Close to 2,000 patients. The first implant was done in August 2016, the last one in March 2019. Now we need 1 year follow-up to see some results. And this was the design of the study. Now, what is important when we perform these studies and what was missing is to have a common language. We have common terminology when we want to compare devices between them or device versus medication. And this is why we put together this manuscript, it took us 2 days of discussions in Munich, and we came to some conclusions. So if somebody is interested, he can find it either in Europace or a Eurointervention journal. And we really encourage people to use this terminology so we can compare, we can have valid comparisons between studies and devices. And in this manuscript, we also have potential indications. And this might remind you the original slide that I showed you with patients with high bleeding risk or previous history of major bleeding. However, there is if you see there on B, the second part, the last part of the lower part of the screen, we do have some cases that we perform that have a stroke on warfarin. So when we see a clot, and we know that it's coming from the appendage, and no matter if the patient had a contraindication or not to receive anticoagulants, he takes it very well, but still has a stroke. So these patients are also for a new potential indication for closure. This procedure was included in the European Society of Cardiology guideline 2012 and then 2016 for management of AF. It does have a class 2B indication, level of evidence B, for patients that are at high risk of stroke and have contraindications for long-term oral anticoagulation. And the reason that, in my opinion, we have a 2B indication instead of a 2A is that we don't have 2 or 3 randomized studies to support that. So there is a lack of data right now. We hope we will work on that and have more data of randomized control studies. Right now, it's a little difficult to randomize patients because they all want to get treated with a device instead of getting medical therapy. But still, we believe that a few studies that are now enrolling will fill this gap in the near future. And this is the ESC guidelines for revascularization, a similar indication there. Now, we finished with part of the data, and now this is a slide that I used in the US a couple of years ago. They asked me to talk about the general principles of LA closure. And I think this is a triptych of success. It is important to know the patient, you need to master the technique, and you need to know the device. And at that time, I was saying we need to avoid and manage complications, but this is a key. Nowadays, after a few years, we have the same boxes on the top, but now we try to perform an optimal closure, which means that we don't just implant the device, but we try to have complete closure of the appendage with good apposition in order to improve our results. And this is an example of how a new technology can become even better with experience. And I will give you the analogy of coronary stenting, where initially we didn't know that we had to post-dilate coronary stents, or we didn't know about strap apposition, etc., etc. And we found that in the process throughout the years of research. So know the patient. Not every patient is the same. Patients come from different backgrounds. They have different histories. So it's important to know the patient before proceeding to this procedure. And part of this is the anatomy. And the thing is that, and this is a big challenge, that the left atrial appendage has an enormous anatomic variability. So you see all these appendages are different. We even call it the patient fingerprint. So how does the appendage form? The formation is, as you see here on A, formation of the primary endocardial tube, and then we have the looping of the tube, ballooning of the atria, and the formation of the appendage. And here, here you see the LAA in the left atrium on a human heart on panel D. So which are important anatomical components we need to know? We need to know, we have information about the mitral valve, which is very close. Of course, we need to know about the interatrial septum because we need to cross it to do the procedure. And also we need to know the left superior pulmonary vein and the left inferior pulmonary vein because they are also very close to the appendage. From the outside, we need to know, of course, whether there's a pericardium, because some patients don't have a pericardium after thoracotomy. We need to know where the pulmonary artery is very close, the left circumflex, the great cardiac vein, and the left phrenic nerve. Now, we have several shapes and several classifications. We have the chicken wing, the windsock, the cactus, the cauliflower, not very scientific terminology, I might say, but people are trying to describe it. And it has been correlated. The LA shape was correlated to the risk of embolization, as presented by Luigi Di Biase in JACC 2012. In the last meeting I was attending, I showed this picture, and here we have on a windsock, a chicken wing, a cauliflower, a cactus. The thing is that if you just rotate, this is the same appendage. This is the same exact appendage. So it has to do the shape sometimes has to do from the projection from which you're looking at it. So what is the answer to all that? Well, we still need to understand the LA shape orientation. We need to understand and measure the orifice, the neck, the depth of the appendage to see how many lobes it has, the connection to the relation to the surrounding structures that I said before. But what we really think is some good imaging, and this is key for a LA closure procedure. For example, we use echocardiography, as you see here, to do the transseptal puncture. We need to do a very careful puncture in the posterior and inferior part of the interatrial septum. You see the yellow arrow. And we use it also, as you see here, this is the bicaval view. So we have a echo-guided transseptal puncture. This is very important to allow us better access. And then during the procedure, of course, we need to check for thrombus. We don't want to push the thrombus out of the appendage and have a stroke. And of course, we need to recognize the several axes of the neck and the body. As you see here, this is the use of ICE, intracardiac echo. It has been helpful. This is another TE view, as you can see. Now, we need to measure the orifice, and we need to define which is the orifice. The orifice for WATCHMAN is different than the orifice for an Amulet, for example, because we put the device in a different place. And we need to measure the neck in several projections. And depending on how we turn our probe, we may find different numbers. And this is the big difference between the TE and CT, is that the operator of the transesophageal echocardiography probe is the one who will decide to push the record button. Whereas when we have a CT, we have more slices and anybody can go back in a good quality CT and analyze it. So we need to have perception. We need to understand what we're looking at, of course. And we have several advantages, in my opinion, of cardiac CT versus TE. We have a higher spatial resolution. We have a lower interobserver variability, etc. And actually, this reminds me of the time when we were trying to convince colleagues to use cardiac CT for TAVR, transcatheter aortic valve replacement procedures. And at that time, everybody was using echo. That was a couple of 10 years ago. And now people have switched. So I believe that this will happen also with LA closure. Now, it is important to have a good image acquisition, and this is some instructions you may use, and this is a protocol. I will not read through that all of it because it's very busy. But if somebody wants to go back and see, this is how they do it in Aarhus, Denmark. And now we need to define the LAAO ostium and then the neck. And this is how we do it very, very briefly. I will show you. It's really very, very easy. I'll just show you a video. This is the appendage on the right screen, on the right part, and you just need to rotate the purple line to align it with where you believe that the ostium is. And then we optimize this, and we will measure, we will define the ostium, some small corrections here, and measure the dimensions. I will move to the next. Then we measure the ostium, as you see here. We take the tool. There are many software available right now. Some are free, others you need to purchase. But it's really easy. And actually, we perform these hands-on sessions in several congresses. There was one in Kansas City a couple of weeks ago that we did. So anybody who would like to come and get the training can do it. It's really not difficult. And then we measure the neck. I will go faster here. I don't want to spend so much time because there are many other things to talk about. What I want to show you is that you don't have to be a radiologist to do that. Once I did an analysis on a podium in 5 minutes. Okay, it might take you 10 or 15 minutes, but still, it's not difficult. So there are some limitations, of course, contrast use, radiation, some hospital logistics, but nevertheless, there are new software that gives you even more beautiful images. This is the one I'm using before every procedure I do in my hospital, so I get prepared before going to the cath lab. Now, and this is how we do the hands-on. Now let's move to the procedure itself. I will just show you one case briefly. This is a 65-year-old male with arterial hypertension, chronic AF. He had recurrent bleeding, so he was planned to perform this procedure. We did a CT analysis. We measured the ostium, as you see here. We used the Amulet device, so we had to measure the LA ostium and then the LA neck, as you see here, and then we had to choose a device, and now you'll see the transseptal puncture.
As we see here, this needle has a marker here where this looks, the tip of the needle looks. So when we say that we're going to do 6 o'clock, it's here, 5 o'clock is there, 3 o'clock is there. So when we want to do the puncture, we go from somewhere between 3 and 6 o'clock. At 3 o'clock is the aorta, which we don't want to puncture, of course, and we must see some tenting. Okay, can you show us now, George, if you have some tenting?
Okay.
Can you show me the short axis now? Yeah, the view with the aortic valve. Less, okay, good. So when we do the puncture, we must make sure we don't puncture the aorta, and we see here on this view that we are far behind. Show me the tenting. Can you show me the tenting? Okay, one more time.
Okay.
Now I'm through. So what we do now, we're going to go at 3 o'clock, everything at 3 o'clock. Now I'm going to advance a little bit everything, then advance only the dilator and the sheath by holding the needle. And then I'm going to unlock this and advance only the sheath over the dilator and the needle, and then I remove that. And that was the transseptal puncture.
So after we do the puncture, we do the angio, and we choose one device size. And this is the correlation between the angiography and the cardiac CT, as you may say. And this is how we do the ball.
So to do the ball, you don't advance this. This is, the right hand is stable, and your left hand is pulling back the sheath, as we're going to do now. Okay? So I'll do it on cine. I unsheath, and I'll do the ball. This is the ball.
And then, as we say, the device, this is an Amulet device that takes the ball shape, and we are in the left upper pulmonary vein, and then we need to put it to the appendage.
So let's go to the appendage. I pull back. I do a counterclockwise rotation and advance.
So we are now in the appendage, and we need to form the lobe of the device in the right position.
Okay. So now we have implanted the lobe of the device.
The next step, in this case, was I had to recapture because we didn't like the orientation of the lobe, so the device can be recaptured.
Recapture means that we are doing the opposite steps, like that. And we're going to do a bit more counterclockwise, like that. And I'm going to redeploy now. Okay, I think that's better.
After we finish with the lobe, we do the disc.
Now I'm going to do the disc.
So as we see the device in place, we do an angiography and we check the 5 signs of stability, as we call them.
Okay, I think it's very good result here.
So these are the signs of stability. We check whether the lobe is in the right place, whether there is separation between the disc and the lobe, and the lobe is deep enough. And then we do a tension test, a tug test.
Now I'm pulling, as you see here.
And when we are happy with the position of the device and we have complete closure, we release.
Now, while I'm releasing, I'm going to pull back slightly, like that. It's 7 rounds. So I'm going to start doing it now. 2, 3, 4. Okay. Okay. And now the device is in place.
We do a final angio.
Great. Let's do a caudal. So the appendage is completely closed.
So this patient was discharged the next day. We do a transthoracic echo, just in case, to see if there is any effusion. The next day, the patient takes dual antiplatelet therapy for 1 to 3 months, and then we have personally, I always do a follow-up cardiac CT in 3 months. And if everything looks good, we keep him on low-dose aspirin for a total of 6 months. So this was the case. Unfortunately, occasionally the cases might not go well, so you need to be very well prepared. And so there are some complications related to the procedure, and I will briefly discuss that with you. Here, for example, you see an embolized device in the left atrium, or you see some air that was accidentally introduced. Of course, we don't want that. So how can we avoid it? You see all these characteristics that the appendix has, and it's a left heart circulation. You need to access through transseptal puncture. It has very thin walls, very variable anatomy. It can blind end structure, so over the wire access is not possible. So the most common complication is device embolization, thrombus formation, cardiac tamponade, air embolism, and vascular complications. As you saw here, I don't want to see that again. Not very nice to see this happening, but still, we need to be prepared. So how can we prevent device embolization? We need to carefully select our patients. We need to use imaging. We need to be very well prepared, well trained, and we should not attempt borderline cases. We need to do correct sizing. We need to check the device connection to the delivery cable, all the signs of stability. And very important, these are self-expanding devices. One important tip is that to wait for the device to settle. Don't go fast. And this is the clock I used in presentations to say that, okay, be patient. Don't go fast. Now, if it happens, you need to manage. You need to deal with that. The good news is that most embolizations occur early, so you need to have available retrieval devices, snares, and large sheets. And it's important to avoid obstruction of the mitral valve or the LVOT. And you need to react fast. And this is an algorithm, and we were asked to prepare on what to do or when this happens. This is published in Interventional Cardiology Clinics. First author is Dr. So. I will not read all the details, but in principle, you need to make sure that the device doesn't obstruct circulation. And if it goes through the aortic valve and goes to the aorta, this is good news. You can easily retrieve it from there. Now, thrombus formation is related to the heparin. We need to give heparin. We should never start operating in the left atrium before verifying an SCT of 250. I would say 300, even better. And keep in mind that thrombus can form in seconds, so you need to be very vigilant, and your echocardiographer needs to help on that part. If it happens, we need to react carefully. Sometimes we use catheter aspiration or local thrombolysis. Now, the cardiac tamponade, this is a complication that is happening less and less now, but still we need to be prepared. We need to be careful in all stages of the procedure. And because this is a very, as I said, very delicate cardiac structure, and also monitoring is important, and having a pericardial drainage kit in the room, not somewhere in the floor. Now, if it happens, there is a question of whether to reverse heparin with protamine. Nowadays, we say don't reverse, just do a tap, and when you drain the blood, then you reverse, because if you have clot in the pericardium, then things can go really, really bad. Air embolism, this is related to flushing of the device, so important to do the wet-to-wet connections and maintain the left atrial pressure more than 10. So if the pressure is low, give more fluid. This will expand, make the appendage expand, and also allow for backflow bleeding through your catheters, so you don't have air that may enter in the system, as you see here in this unfortunate case. Well, the patient did well in this one. There's not much to do. Basically, you give nitrates maybe sometimes, or 100% oxygen. Vascular complications are still happening. These are not specific for LA closure, but we need to make sure they don't happen. Nowadays, we have stopped putting an arterial line. We don't need a femoral artery, so just use the vein. Sometimes we use echo-guided puncture for the vein or a microneedle. Still, it's 1/3 of the bleeding events that we see is related to vascular complications, so we need to be very, very careful. Just a few words on a paper that was published on the antithrombotic therapy and device-related thrombosis following LA closure. This was published recently, not in 2010, as it shows here, I think it's 2019. So all patients receive aspirin, but again, you need to know your patient. Sometimes you will modify your antithrombotic therapy depending on the history, depending on what happened in the past. For example, these patients, if they are ineligible for even short-term full dose therapy, you may give half dose. Again, we don't have randomized data on that. It's more empirical, but still you need to think. So when you have a high risk of thrombus formation, like when you have incomplete LA closure, a large left atrium, we have a history of thrombosis, a history of pulmonary embolism, we have spontaneous contrast on TE, then you need to take this into consideration. Again, depending on the indication for closure, if a patient has a high bleeding risk and has a GI bleeding, maybe we'll treat him a little differently, whether depending compared to another patient that had just a stroke on warfarin without any contraindication to it. Again, we evaluate the risk of bleeding. If the patient had a history of major or minor bleeding, sometimes patients have bleeding even with single aspirin therapy. So again, it's important to know the background of the patient, the history. This is a table we have prepared on which one favors a shorter DAPT or single adapted therapy or even no therapy, and other variables favor longer DAPT therapy or even oral anticoagulation. So to conclude this presentation, I have 2 slides of take-home messages. One is we say that AF-related stroke leads to significant morbidity and mortality. So there is a clinical need for a local therapy, as we call it, for AF-related stroke. The first LA closure procedure with a dedicated device was performed back in 1998. And then the WATCHMAN device has shown improvement in mortality and has the most clinical data as compared to warfarin therapy. We have results from large registries that are very promising, both in terms of safety and efficacy. The main indication for closure is non-valvular AF and a contraindication to oral anticoagulation therapy. Of course, there are other indications, but when somebody wants to start the program, maybe should follow the main indication and not do deviations. The general principles of closure is to know the patient, know the device, master the technique, avoid complications like the one I showed you at the end, and perform an optimal LA closure, no leaks and good device acquisition. Of course, the appendage has a very variable anatomy, so we need to have a very good imaging. And I believe that cardiac CT has several advantages over TE, and I hope this will be gradually adopted worldwide. At the end, proper patient selection and collaboration between the interventional cardiologist and stroke neurologist or other colleagues is the key for success. And I will finish this presentation with a quote by Socrates, saying that the only thing I truly know is that I know nothing. Thank you.
Thank you, Dr. Apostolos Tzikas, for sharing your expertise with our participants. I'd like to open our question and answer session. If you would like to submit a question by the Q&A box, you may enter it now. And here is our first question. It reads, what type of patient has the stronger indication for LAA closure today?
Yeah, this is a question that is not easy to answer, of course, but I believe, based on the current data that we have, is that an ideal patient would be one that had the previous intracranial hemorrhage or a contraindication to oral anticoagulation related to lesions in the brain, because the consequence of a subsequent or a second intracranial bleeding might be really devastating. You know, a nosebleed or even gastrointestinal bleed can be most of the times easily managed, but intracranial hemorrhage is really bad. So I think that the main target would be these patients, without excluding the others, of course, but I believe these have a stronger indication.
All right, thank you. We do have another question, and it reads, how would you describe a perfect LAA closure device?
Yes, this is another good question. You know, these devices are designed to, specifically designed for LA closure. Unfortunately, due to the variation of the anatomy, it's very difficult to have one device that will fit all anatomies. So one important thing is that the device must be conformable to anatomies. The other thing is that it shouldn't cause thrombus. It shouldn't be thrombogenic, because there are some few cases, like 1 to 2% of cases, that there is thrombus that develops on the device. So we need to have a device that doesn't promote thrombosis. Another important part is that the device has to be user-friendly. So the operator that will use it should not need 30 procedures to learn. So the learning curve of the device must be relatively fast. Another important element is the data. We need to have data. We cannot use a device without clinical data. Not all devices are the same. Even small variations may change the outcomes. So we need to have evidence, published clinical data that this device works. The better would be to have randomized data, as we have with WATCHMAN. Unfortunately, this is not the case, and is sometimes very expensive and very difficult to perform these studies. But surely we should aim to have evidence that a particular device works. Another important part is the cost, because not all health systems can get these devices. Some countries, poorer countries, might not be able to offer them to patients. So it's important to have a relatively reasonable cost. And of course, this goes with the widespread use, like we have coronary stents. If we use them more, the cost is less. To have less complications with these devices, and on that part to have a safe system to use, and others. Unfortunately, we don't have an ideal device yet. And this is another question you may want to answer. But we are working on that. Now, I believe with new material that are gradually used in interventional, in medicine in general, and in interventional cardiology, I think that soon we will come up with different designs and more sophisticated devices to use them for, as we call it, local therapy for stroke prevention in atrial fibrillation.
Thank you. Unfortunately, we've run out of time for questions. We would like to thank Dr. Apostolos Tzikas for presenting this exciting informational webinar activity, and we hope that you'll be able to use what you learned today in your area of practice. At this time, I would like to thank our presenter and today's audience for participating in our webinar. Thank you for joining us. We hope to see you at a future webinar.